Good enough. Welcome to IFARA's treatment update for 2014 at CROI 2014. I am joined by two wonderful doctors. I've got Dr. Dan Kuritzkes next to me, Dr. Phil Grant. Thank you for joining us. That's really, really good. So I guess we'll just get it kicked off. There's been quite a lot of talk about different antiretrovirals at this conference, and treatment in everything from infants all the way through to those that are pushing the retirement card. So anything strike you as new, novel, fun?
I think there were a couple of really interesting presentations about antiretroviral therapy. Probably the most interesting were the data from the LATTE study about long-acting therapy, because I think if you're talking about really new horizons in antiretroviral therapy, it's not bringing on another drug in a new class so much as it is how can we really break the paradigm of having to take one pill every day, and that would be having to take something only once a month or maybe even once every 3 months. And so this study showed that at least the drugs that could go into a regimen that might be long-acting were effective at sustaining viral suppression and were well tolerated.
I think that's really a good thing too. That would also be helpful in a lot of people that might be HIV positive, taking medication that aren't in the best of living situations, maybe homeless, wouldn't have the opportunity to have monthly medications in a place where they can access them. And they might be able to go to their doctor, I guess.
Well, I think the greatest potential for these long-acting regimens is exactly the group of people you were just describing, the difficult to access, difficult to treat patient populations. Because I think people who are able to take a pill a day are probably going to be pretty happy just continuing to take one pill a day, and probably won't want to come and see the doctor every month, since they're now seeing their doctors every 3 to 6 months, and they're probably not going to want to get an injection if they could just swallow a reasonably small pill each evening. But if we can really put the infrastructure together to go out and treat people who need to be treated but are having trouble getting in to see their doctors or getting into their clinics on a regular basis, I think first we could do a world of good for those patients, and second, that has the potential to have a huge impact on transmission and on the epidemic.
I guess it really widens the horizon in the tools that you would have to treat people. Now, you were in the Bay Area, Dr. Grant, and I imagine you probably see quite a few people, and that would be useful for you as well, the longer-acting regimens. Is there anything beyond that excited you this conference?
Well, I think a really important study was a study that compared raltegravir to 2 protease inhibitors, and they're all currently recommended for first-line therapy for HIV. And generally, people have been thinking of them as relatively similarly effective, which a study from the ACTG did show that they were similarly effective, but the side effect profile of the integrase-based regimen was substantially better. So I think it really is going to move us more away from protease inhibitors for first-line therapy. And I think there's been a general trend towards integrase inhibitor, but I think this is going to continue that trend, at least in the United States.
Yeah. So I think, unfortunately, there's a lingering stigma associated with antiretroviral medication. People have heard about drugs that were used 20, 30 years ago, and there's still fears about those more pronounced side effects than regimens like you're discussing. So I think the simplification, the less likely that people are going to have adverse side effects would probably just make that even better, wouldn't it?
It's important. I think it's interesting. Early in the epidemic, fears of side effects were some of the advertisements that were used to get people to use safer sex. And so I think a lot of the early protease inhibitors and the side effects that were quite visible really have, like you said, remained in people's mind. And there's still a lot of patients who have a lot of fears about medications and the side effects, both both kind of realistic fears of the side effects and also blown out of proportion. So I think as people do get on the newer, better tolerated regimens, hopefully some of that concern will dissipate, because I think it really doesn't affect a lot of people's ability to take pills reliably, that fear.
Yeah, definitely. So I imagine there's two different worlds that you would see, but each being on different coasts of the United States. Maybe in San Francisco area, it's a little more condensed, and here in the East Coast, we've got populations spread all throughout the Eastern Seaboard that no doubt you're getting to see more than just in the Boston area, and is the simplification of long-acting regimens, better tolerated regimens, and potentially even a couple of new drugs, something that is appealing to the patient population out here?
Oh, certainly. I think that tolerability is always going to be one of the key factors that drives people's willingness to take medications, to take them regularly and to stick with it. For at least one of the drugs that was used in the ACTG trial that Phil was just talking about, a side effect is jaundice. Not a medically significant problem. It's not because of liver damage, it's just because of interference with metabolism of the bilirubin pigment that is what causes the jaundice. But nobody wants to walk around with yellowish skin or yellow eyes, and it's certainly, when you talk about stigma, it's certainly something that identifies you as potentially being on antiretroviral medicines. And so from that perspective, it's not too surprising that raltegravir, which doesn't have any of these side effects, did substantially better than the atazanavir containing regimen when compared based on tolerability, and in the overall analysis that lumped tolerability together with virologic success. And I think there's as you point out, quite not only is the epidemic extensive up and down the East Coast, but there's quite a range of diversity in whom the epidemic affects up and down the East Coast. Here in Massachusetts, it's still predominantly an MSM epidemic, but if you get down into the Mid-Atlantic, it's a much larger drug injection population. And then, of course, in the south of the United States, it's a much more heterogeneous epidemic.
And that also, I guess, would get into different populations that culturally may be a little bit more sensitive to certain medications as well. Mm-hmm. Not necessarily for what they do inside your body as much as you say, jaundice might be something that's very stigmatizing. Now, do you also see with the future that we've got here in this country, does that also portend for a better future for developing countries? Are they going to start being able to get more modern regimens coming out and be able to benefit from what we've learned here?
Well, I certainly think the knowledge that we have here translates easily to the developing world, into resource-limited settings. The principal issue is an access one, and getting the pricing right so that drugs can be made affordable in resource-limited settings. Part of the issue is also about formulation. So with raltegravir, because currently it's a twice-a-day drug, it may be less easily used, certainly not as a single tablet regimen, and there are some advantages in terms of treating large populations to having a single tablet that can be used. But dolutegravir, which is also an integrase inhibitor and was previously shown to be superior to the boosted protease inhibitors in a trial presented at an earlier meeting, could be co-formulated into a once-a-day pill. It's just a matter of first getting that formulation and secondly getting the price right.
Sure. Well, and I guess there are regimens that are still out there that are not one pill once a day, and I guess the better you get the medications, the more streamlined you can get your regimens. Probably your patients would appreciate that. once-a-day dosing? Is that something that you hear as being a desirable?
It depends on the patients. A lot of my older patients that have lived through the epidemic are already on a very long list of medication. So people are pretty happy with their regimens, that they're working and well tolerated, and whether it's 3 or 4 pills or once or twice a day. A lot of their other medicines are twice a day. So I think it really depends on the patient. I think the younger generation, I think that's really definitely true. It's a very common request to have a 1 pill once a day formulation. But I think it's important also that patients recognize it's not a one size fit all, because a regimen that might be 1 pill might not be right for them based on resistance they may have or how severe their disease is. So I think it's because of all the marketing around 1 pill once a day. I think people may think it's more important than it is. I think I think it's definitely needs to be individualized for each patient.
Yeah, potentially. I guess a patient could get disappointed when they come in and they learn that a 1 pill once a day regimen isn't maybe the best regimen for them. But you said multiple medications. Now I imagine you're talking about things that would include maybe statin drugs, possibly medication for diabetes, high blood pressure. The list probably goes on and on and on. Are there a lot of issues with drug interactions?
I think drug interactions are an important part of managing patients with HIV infection from a clinical perspective, knowing which interactions may be harmful, when you can use certain drugs but not other drugs in combination, or how to adjust the doses of those drugs. And that's something we've been dealing with really for at least 15 years, maybe even longer now. Luckily, some of the newer drugs that are coming along seem to have fewer of these interactions, and I think that's a big advantage because as our patients age and as the epidemic ages, particularly here in this country, more and more people are going to need to take the drugs that all the rest of the of older Americans take, and
everybody's getting older,
right? And that means looking out for more of these interactions.
Yeah. But the breadth, I'm sure, of the different antiretroviral medications makes that an easier task.
It does, and I think that's why Phil's point about individualizing therapy was such an important one.
It's good to hear that your patients are also willing to do this.
Yeah.
That's terrific. So maybe getting out of the adult world and going back into the youngsters, there's been quite a bit of talk. In fact, even this morning on the news, I saw something about another infant that could potentially be, I don't want to use the word cure, but I'll say in remission, much like the Mississippi baby, or at least is being compared to the Mississippi baby. What have we heard at this conference regarding regimens and treatment changes for infants and newborns?
Well, I think the big challenge is that there are so few drugs that have been shown to be safe to give to very, very young infants, essentially right after birth, which is what might be needed to protect those kids who are somehow not getting protected while their moms are pregnant. And I think it's important to say, first of all, that we've done an extraordinary job here in the U.S. and throughout the developed world, and increasingly in the developing world, at preventing mother-to-child transmission by testing women who are pregnant, identifying those who are infected, and getting them on antiretroviral therapy, which has reduced to really a handful of cases a year the number of kids who do get infected in the United States. There are still some kids who somehow slip through the cracks, and in that situation, if you can get infants treated immediately, there may be the possibility of completely preventing the infection or eradicating whatever infection occurs. And then the challenge is, what drugs are safe to use? And there are only a handful of drugs that we know are safe to use in that setting. The protease inhibitors at the moment really can't be used until the 2 weeks of life, and then there's the issue of which ones of them can be administered in a formulation that can be given to an infant, liquid formulations or intravenous formulations. So there's still a great deal of work to do. The challenges are even bigger internationally and in resource-limited settings, because there, if prevention has failed, the baby may be exposed to a resistant virus, and so you don't want to use drugs to which the baby's virus might be resistant. And too often, kids are also exposed to TB or may themselves have tuberculosis, and that limits to a great extent the drugs that can be used because of the drug-drug interactions we were talking about just a few minutes ago. And so I think there's still major challenges.
Wow, that brings up a whole different set of issues. I imagine as a clinician, sometimes it's a little, I guess, frustrating when people that turn on the news and hear about cure, maybe they come into your practices and say, I'd like to have that, rather than a triplet.
I don't see it that way, really. I mean, I appreciate that. One of the reasons I got into HIV medicine is that patients are involved in their care. And so if most of the patients that I see are quite educated about what's going on, I had a different story, but not that different, where someone had been treated very early on in acute infection and had been suppressed for a very long time. I was wondering, he had heard some reports of people that had been treated very early on that had been at least also in remission, had controlled their virus without medications. So he wondered whether that was right for him, whether after a few years of therapy it was right for him. So I think it's kind of our role of a doctor to communicate to patients and discuss what the costs and benefits of various interventions are. I mean, the most frustrating thing to me is when there's misinformation that's been received. I've had very educated patients stop therapy because they read about all the poisonous things that are going on, just based on various HIV nihilists. To me, that's I don't really blame the patient. I just kind of blame the society that we live in, where the internet, it's very hard to filter truth from fiction. But people that listen to conference news and want to have it explained to them, I appreciate that, because that's one of I think the benefits of our patient population is how engaged they've always been in their care.
Well, that's good, because we know that doctors are a little bit spread thin, especially with the Affordable Care Act, getting more patients into care, and I'm sure you'd like to have a little bit of time just to eat lunch rather than have to, diffuse situations from what's been read in the internet or heard on the media. I think lastly, I'd like to just ask both of your opinions on treating with acute infection versus maybe waiting. I mean, it has implications for eradication strategies, but it also may have a very direct impact on the patient's health.
Yeah, I think that just as with other treatment decisions, the decision to treat during acute infection needs to be individualized. I think we do have quite a lot of data that suggests that treating early helps to limit the size of the viral reservoir. It more quickly restores the immune system back to normal. And whether that has long-term benefits or not is a little harder to say at the moment. We don't know what eradication strategies may come down the road, and so I don't think we can sell...
Or how long they might take.
Or how long they'll take. So I think we have to be careful about selling to our patients, you should go on treatment now, because in 5 or 10 years you might be in a better position to be cured than if we wait. However, I think that there's enough evidence that we want to treat patients from the time of diagnosis in any respect, and therefore why would you treat acute infection differently than the person who's diagnosed when they've already been infected for a little bit of time. The reason I say the decision has to be individualized is some patients may not be ready at the time they first get diagnosed with HIV to commit to treatment. And then unless they're having significant symptoms or feeling really ill from their acute HIV infection, it may be that they need a couple of weeks to get used to the diagnosis, understand the implications, and be ready to go on therapy. the big reason that you, in addition to the person's own health, that you'd want to treat is people are most infectious during acute infection because they have such high virus loads. And getting people on treatment and getting their virus load down can help to prevent onward spread of the virus as well.
Excellent point. Excellent point.
No, I agree with Dr. Kuritzkes on that. I got a call just yesterday from a nurse practitioner who's still in clinic. Same question. Someone that come in. Unfortunately, access to care is an issue a lot of times now. You're getting paperwork ready to get on medication. So I think unless one's enrolled in a clinical type study, it may be hard to get on medications right away, or at least, because I had heard about the case about a week ago before. He had been in the emergency room diagnosed with acute HIV in the emergency room before we could actually get him in care. It was a little bit later. I think when I started HIV in residency in medical school, there's a pendulum, as you all may remember, and you probably were teaching the pendulum. There was a cost of medication and a cost of the virus.
Right.
And we kind of looked at that, and I think our perception of those costs, we never really thought about HIV as causing anything other than AIDS. There was for quite a while a period of time an asymptomatic or latent period. I think the thinking has really been changed quite a bit in the last 6 or 7 years. So I think the way that scale tips is much more that the virus is causing a lot more damage than potentially some of the medications could in terms of side effects. So for me, if I was a patient, it'd be a relatively straightforward question. But as Dr. Chris says, a lot of patients may have other things going on that preclude them taking early medication.
Nothing's ever simple. Nothing's ever simple. Well, certainly we appreciate your taking time out to join us and lift the veil of some of the confusion on antiretroviral treatment for this year, and we'll see what happens next year, and maybe those long-acting drugs will be even closer to being available. Yeah. But thank you both very much. I definitely appreciate it. IFARA appreciates it. Our viewers appreciate it.
My pleasure.
Thank you.
Thank you.